Welcome, everyone, and thank you for joining us for today's session, Frequently Asked Questions on Treatments, Monitoring, and Maintenance for Newly Diagnosed Multiple Myeloma Patients. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I am joined by Dr. Sergio Giralt and Ms. Emily Patterson from the Memorial Sloan Kettering Cancer Center in New York City, and Richard Knox, a patient from Charlottesville, Virginia. We've invited them here today to answer some of the frequently asked questions we receive from patients and caregivers about initial treatments, maintenance therapy, and monitoring for newly diagnosed multiple myeloma. We hosted a webinar on this topic a few weeks ago, and we received many more questions than we could possibly answer during the time of the webinar, so hopefully we can get more of those questions answered today. So let's start off with some questions about induction therapy and whether myeloma stage matters with respect to treatment choices. Dr. Giralt, for a patient who's just been diagnosed, how do you and the patient decide on the best course of treatment? And does being stage 1, 2, or 3 factor into that decision?
Well, Mary, first, thank you very much for inviting me, Emily, and Rich to this webinar, and we welcome the patients, their caregivers, and all interested parties who are here. I'm Sergio Giralt. I'm a professor of medicine at Weill Cornell Medical College, and I'm the deputy division head of the Division of Hematologic Malignancies at Memorial Sloan Kettering Cancer Center. So myeloma staging is actually very interesting. Myeloma is a blood cancer, so it's not like breast cancer where it's staged by size and if you have lymph nodes involved in this. So myeloma is staged what we call the international staging system, in which we measure albumin, which is a protein that we have in the blood, and beta-2 microglobulin, which is also a protein that's established in on myeloma cells. So if your beta-2 microglobulin is very high, more than 5, you're called a stage 3. Now, there's also the revised ISS, in which we incorporate chromosome abnormalities. There are a variety of chromosome abnormalities that we call high-risk cytogenetic abnormalities. That just one of them is a deletion 17, 414, 1416. The presence of these chromosome abnormalities in the myeloma cells predicts for a worse outcome. Does it make a difference? Well, when we see an initial patient who presents, it depends on how they present. A patient who presents with renal failure is actually a medical emergency that requires admission, plasma exchange, hydration, so that we can preserve and save kidney function. A patient who presents with a cord compression because of plasmacytoma is a medical emergency. But once the most common presentation in the United States today is a patient who presents with fatigue, bone pain, or serendipitously was getting their yearly physical examination, was found anemic with an elevated total protein. At that time is referred, and the first thing that one does after making sure that there's no emergency is to stage that patient. And the staging involves the blood work, a bone marrow, and a total body imaging, either total body PET-CT or total body MRI. And then with that piece of information, the hematologist, oncologist, the myeloma specialist sits down with the patient, and each patient is an individual, depending on their performance status, depending on their age, they come up and devise what we call the induction therapy. Patients with stage 3 disease are patients at high risk. They behave differently than patients with stage 1 and 2 disease. Actually, some patients with stage 1 disease, many times we don't treat them. They fall into that category of smoldering or asymptomatic. They have no symptoms. So we might watch them for a period of time because we don't know whether they really have active myeloma or they're basically just plugging up, their myeloma isn't moving and isn't causing them any problem. Patient with stage 2 disease usually all have to be treated. So what's happening now, and I'm sure in the webinar they explained that, we really recognize that 4-drug induction is better than 3-drug induction. And for many patients, yes, 4-drug induction involves a little bit more treatment and sometimes more side effects. But if you have stage 3 disease, it makes a dramatic difference. Currently, I think we are moving more and more towards 4-drug inductions for everything because the results of the Griffin trial and the Cassiopeia trial are fairly dramatic.
Yeah, agree with that. There's a lot of talk about that these days. So, so Emily, it seems like all treatment regimen options offered to patients when they're newly diagnosed have dexamethasone as one of the drugs in the regimen. And it is often poorly tolerated by patients, and they complain about it quite a bit. I'm sure that you hear about that a lot. So can you tell us why it's used, and are there ways patients who have to be on it can tolerate it better?
Sure. Again, first, thank you for having me and letting me join Dr. Giralt and Rich in this conversation. But you're correct, dexamethasone is often used and most often used as part of induction therapy, and is one of the 3 or one of the 4 drugs used in triplet or quadruplet combination therapies. So the primary reason is that it enhances the potency of the other drugs. It is used in conjunction with Revlimid or lenalidomide being an example of that. It is also used to combat the side effects of treatment, such as nausea or allergic reactions that we can see with something like daratumumab or even rashes with lenalidomide. But in order to tolerate steroids or dexamethasone in particular better, we do recommend taking it first thing in the morning and with food to minimize issues related to insomnia or GI upset. And it should be taken with an antacid, and drugs, over-the-counter drugs like omeprazole, which is Nexium or Prilosec, can be used to protect the stomach. And then for more serious complications from dexamethasone, such as high blood sugar, high blood pressure, or mood disturbances, dose reduction is often recommended. And then in more severe cases, the drug can be stopped.
Okay, so Rich, your turn. Let's hear your story. Can you tell us how you were diagnosed with myeloma and what initial treatment you received, and how did you decide on that treatment?
Yeah. Thanks, Mary. Yeah, it is real joy to be here with Emily and Dr. Giralt, and thank you for this opportunity. Flashback to December of 2011. As a minister, Advent is an extremely busy time right before Christmas. And I was gimping along, and I had to tell people in church, don't tell Nan, my wife, that I'm limping or anything like that. But I was limping. And it was midweek, end of a long day. I went down to where the church had a tutoring program, and one of the high school tutors was done, and her mother was a colleague of mine in a different church, and I needed to talk to her. So I said, Rachel, I'll walk you out to your car. So I walk out with her, and I hear the bzzz, the window comes down, and lo and behold, it's not her mother, but her father, who happened to be my primary care physician. And he says, you're limping, come into my office next week. In other words, immediately after Christmas. And I said, Tom, come on. I don't have any more money in my flexible health plan. I'll come in next week. So I did. He sent me to a physiologist. And I went to the physiologist. The physiologist says, oh, yeah, this is pretty much arthritis. We'll just do a quick, X-ray and go from there. But I did forget, Christmas Eve, I had baptized twins year and a half earlier or so, and they were coming to the children's Christmas Eve program. Mm-hmm. I always try to see people eye to eye, so I bent down, and I had sharp pain right here in my chest. That's the only pain I ever had with my experience of multiple myeloma, except for the bone marrow transplant. I mean,
the bone marrow harvest. The bone marrow
harvest. Yeah.
The bone marrow aspiration.
Dr. Giralt likes to say the woodpecker. Here comes the woodpecker. but so after the physiologist calls back after a couple of days and said, I need to have an MRI. My antennas just went up like nobody's business. And I said, I will come and pick up the script and take it to the MRI office. I take it in and said, I'm not leaving here until I have had this. They thought I was joking. I just sat down. And lo and behold, within a half hour, they had me out of there. But then he calls and says, the physiologist calls and said, Tom's just expecting a call from you. Give him a call. I called Tom. And it looked like it was myeloma, but they weren't sure. They just looked that way. So he said, come in. for an appointment, and he asked if I wanted a second opinion from Memorial Sloan Kettering. That again was a no-brainer. But he put me in jail, meaning the local hospital, for a whole bunch of tests, so I wouldn't be walking on my leg. I go in, and Dr. John Healy, who was orthopedic oncologist, who I interviewed with initially, and he kept saying, yes, yes, good, yes, yes, the entire time. And then he said, this is what we're going to do. I'm going to admit you to the hospital right now, and I'm going to operate tomorrow. And he replaced my left femur.
Really?
Yeah.
Wow.
Yeah. And apparently I had, I had shattered it from the inside out.
Oh.
And so I was in the hospital a long time for that, because I was in traction for an extended period of time and then just getting ready. But because of that pain I expressed on Christmas Eve, that was a tumor that was up against my spinal cord. And so they decided, my understanding is that they would normally do any surgery, then chemo, and then any radiation, and in that order. They felt they had to do radiation right away. So we started at the back end of my time in the hospital. So I was learning how to walk again, walk with a walker, crutches, a cane. And then, so we did 15 sessions of that. Then we started with the Velcade, dexamethasone, and Revlimid for me, just to knock it down as much as we could until it got to a good level. Then we stopped a little while for my bones, for my body to rest. Then we harvested my stem cell, and then 2 days and a decade ago, I had started my transplant. My day zero was June 27th of 2012. And so that's how we got into it.
Mm-hmm. Mm-hmm. It's quite the story. Quite the story.
And 10 years ago, which is really great. And,
He's
very active, has grandchildren.
Mm-hmm.
And, it's for those of you out there, it is incredible that, things have changed a lot in the myeloma field and induction. The transplant component, I guess, we still use melphalan at high doses. Many centers are now doing outpatient transplants, which is a change. And it's actually, for many patients, outpatient transplant is, really a game changer, because it allows them to live in a homebound environment. And actually, some Duke and Memorial now are actually doing a study on homebound transplantation, where patients actually stay at their home or in a home-like environment. And the nurse practitioners and the medical team goes, and with telemedicine now, many of these things are much more feasible.
Yeah.
And we are studying ways that we can make transplant much easier and with less toxicity.
Mm-hmm. Mm-hmm. Good to hear. I know that that's a sort of a field that's near and dear to your heart, Dr. Giralt. You are a transplanter at heart. So, but let's talk a little bit about bones and bone lesions. I'm really interested to know when somebody replaces your femur, what do they put there instead? Is it like an iron rod or something, or?
It's titanium rod. Yeah, yeah, and it's when Dr. Healy was putting it in, he said the only pristine, talking about bone lesions, the only pristine part of my bone structures was my left socket. So that's still me. That's mine. And but the femur itself and the ball is his. and so right now, occasionally I have a little bit of arthritis there, but it's a good trade-off.
Yeah, I think so. So speaking again about bones, many patients have bone lesions at the time of diagnosis. So Dr. Giralt, does treatment, like induction therapy, help the bone lesions to heal? Or do you have to give other treatments? And what's the best way to deal with this, bone pain and bone lesions?
So it's interesting that Rich described this as, his femur shattered from inside out. Because what happens is, as the myeloma grows, it destroys first the inner part of the bone, what we call the bone stroma. You got to think about the bone as like a sponge, right? That soft part of the. So what is it growing there? It's starting to destroy the walls of the sponge, and it creates a larger cavity. Eventually, it starts growing and it starts eroding the cortex. The cortex is that hard part of the bone, the thing that gives it its strength. And as it grows out, it breaks the cortex. You can also imagine that it weakens the cortex. So what is the common story with a myeloma patient is, I lifted my granddaughter and suddenly my humerus cracked. Or I was lifting a shopping bag and I fell and I cracked the hip or whatever not. So these are what are called pathological fractures. So in many cases, when we do that total body imaging, one of the things we're looking for is what we call lytic lesions. These are the holes that the myeloma grows as it grows locally. If a lytic lesion is actually eroding the cortex of a weight-bearing bones being your lower and your upper extremities, or if they're eroding your vertebral bodies, there's a risk for a compression fracture. These patients are what we call prophylactic irradiated, or in Rich's case, if he had discovered this before he fractured, he would have been prophylactically taken to surgery and put the metal rod to avoid a pathologic fracture. Well, what happens if a patient doesn't have those? Does that mean that their bones are healthy? No. By definition, all myeloma patients have a proclivity for fractures. We do a bone density at baseline, but because treatment can, even if your bone density is normal, treatment for myeloma itself can cause loss of bone, of bone. So these patients get what we call bone strengthening medicines. Two types. One of them is the bisphosphonates. There are two available. One's pamidronate and one's zoledronic acid. The one that's most commonly used is zoledronic acid because it can be infused over half an hour to an hour. Pamidronate requires 90 minutes to 2 hours. The other one is a monoclonal antibody called denosumab, which commercial trade name is Xgeva. These are equivalent. They're very good in making, and they reduce the risk of what we call skeletal related events or pathologic fractures. In addition to that, patients should be taking vitamin D to make sure that their vitamin D level, which is essential for bone health, and on certain occasions, calcium supplementation.
Perfect. So, Emily, tell us a little bit about these bone strengthening treatments, Zometa and Xgeva. How are they incorporated into the treatment schedule? How often do patients have to come into the clinic to get them? And how long are these types of treatments given for?
Okay, so sort of just carrying over on what Dr. Giralt said. So Zometa, Xgeva, pamidronate are often started at the same time as induction therapy. And like Dr. Giralt said, both as treatment and prevention of bone destruction from myeloma, and also from the treatment itself, i.e. the dexamethasone or the steroids. So we will start with a skeletal survey or a DEXA scan, which assesses the bone density prior to initiating therapy or around the same time, just to see, where are we starting with the bones? Do we have normal bone density? Are we in between with osteopenia, or do we have osteoporosis? And generally, we do recommend starting treatment every 3 months, regardless of what that bone density scan shows, for a 2-year period, and then reassessing with another DEXA scan, so re-imaging the bone strength and dosing further based on those results. So if your bone density got a little bit worse, maybe we're going to continue every 3 months, versus if it got a little bit better, we could space it out to every 6 months, maybe even yearly. You also have to base it upon, what your myeloma is doing. Are you having more bony lesions? Are the bony lesions stable, or do you not have bony lesions at all? We can administer the medication on the same day somebody's coming in to get their myeloma treatment, just to minimize clinic visits. But some people don't want to have such a long day if they're getting a lot of infusions, and so they don't have to be the same day. You can spread them out. So it's really just patient preference in that regard.
And it's important that some physicians give it monthly, which is the way they were approved. We do every 3 months because, I mean, there is data to show that it's as effective and it's obviously less treatment burden for the patient.
True. So Rich, and you had your limp, right? And then you had your femur replaced by a titanium rod. So was that the only part of your bones that was affected by your myeloma? And did you take some of these bone strengthening agents, and how were they for you? Did you have side effects from them? How did that go?
Yeah. Thanks, Mary. We call it multiple myeloma, meaning it was a lot of places. But obviously, the most critical initially was my femur. But that pain that I very well may have been a broken rib, and my recollection is that for me, the signs of the skeletal myeloma that I had was on my left side, and so my pelvis. We'd like to remember past tense that my bones were like lace, and so I did. I had lytic lesions, and I will badmouth the New York Times spelling bee for not accepting the word lytic in the spelling bee. but besides, it's a common word in our household.
I'll tell you that our chief medical officer often posts things on Facebook where he's putting medical terms into the spelling bee, and they're never accepted, and makes him irritated.
Yeah, well, for me, it's also theological terms too.
Oh, there you go.
Right. But so I did have my pelvis was affected, probably right up here, and in my femur. I was treated, and I'm still being treated with Zometa. Initially, if I recall, Dr. Giralt, I think I was almost monthly with Zometa initially.
In the beginning, because you had so much, and then we spaced it out to every 3 months.
Right. Yeah. And now it's still going on, but it's once a year.
Oh, great.
I did take, and I still take the calcium supplement, and vitamin D, and then just a regular old man's Centrum over the male multivitamin, and that's it for that. But my understanding, and we'll talk to the boss. My bones now are in fairly good shape, I think.
That's good.
Your bone density has increased significantly, and there is a question of whether we can stop the Zometa, which we have stopped in patients whose bone density returns to normal, and because you're only on maintenance lenalidomide, so you're not on on steroids. I think that and monitoring bone density is. And what's interesting, Mary, is I think we are now. The number of 10-year survivors for myeloma is increasing significantly, and many of these myeloma, and hopefully many more people will be like Rich, where myeloma is something they just have as maintenance treatment. So we are trying to, there is a survivorship issue, is how can we make sure that Rich gets to his 80s and his 90s in his healthiest way? Right. So there is a whole program about survivorships after, long-term survivors for myeloma. He has a skin exam once a year, his dental exam once a year. And, there's a bunch of surveillance that we have to be done. And he had his baby shots again.
Right.
The baby shots. That's
funny. He stays up with his vaccinations, which is very important.
But because I see my dermatologist twice a year and the dentist 3 times a year.
Okay. Very good.
Just to keep watch.
Yeah.
Good for you, Rich. Keep those doctors on their toes. Okay, so we're going to switch gears a little bit now. Talk a little bit about newly diagnosed patients getting COVID vaccines and the boosters and the timing of those things. Does this take place before treatment begins, or what are the current recommendations on that? It's like COVID seems like it's here to stay and it's not going away.
That's it. It's here to stay. It's not going away. So We follow exactly the guidelines of the CDC. We're telling patients as soon as they're diagnosed, they get their shots. They should have their 3 booster shots. We monitor the COVID spike. A patient who doesn't develop COVID spike, we give them the long-acting monoclonal antibody to keep them protected.
Mhm.
As important as the vaccination is, maintain social distancing and the use of mask. If you are, if you're immune compromised, you should not be exposing yourself to risk. There's still a lot of COVID out there. The current variant, yes, it seems to be less, we'll say, it's more contagious, but less virulent than the original one in Omicron. But I mean, people can still get really sick. And we unfortunately have lost patients to this variant of COVID. So I think my recommendation to all myeloma patients is get vaccinated, get boosted, get reboosted, monitor your titers. And very important, social distancing, mask wearing, and a lot of hand washing, and avoid people who are sick.
Yes, absolutely, absolutely. We certainly are seeing evidence of that. We've tried to go back to doing live patient education events in various cities, and we're just not getting very much attendance. And you can't blame patients because patients need to be safe.
Yeah.
So, and not everybody is responding to the vaccines or being protected by them. So,
and there's still a substantial proportion of persons out there who are not vaccinated. So.
Absolutely.
And the kids are, and thank God the kids are going back to school. I mean, look, we're seeing COVID amongst our patients who are vaccinated. It's generally very mild. And they just they quarantine for 7 days, and then we go back to your life. And we will tell them all, call as soon as you're positive, and we prescribe Paxlovid.
Yeah, right, great. So that's good. Okay, so Emily, we're going to switch gears a little bit again, and we're going to talk about patients who have progressed to active myeloma from smoldering myeloma. So you can talk a little bit about smoldering, what that is, and are there treatments for this, for somebody who has that, right? They were smoldering and then become active. Are there treatments for that individual the same as somebody who hadn't been diagnosed previously with smoldering myeloma?
So I'm going to have Dr. Giralt help a little bit with this question, just because I often saw a lot of patients post-transplant. But generally speaking, patients who progress from smoldering myeloma to active myeloma would receive the exact same treatments as somebody who was diagnosed with active myeloma from the beginning. They would receive the same triplet or quadruplet therapy. There are treatments for smoldering myeloma, daratumumab being one of them that is being studied. So yes, we can initiate treatment. It's a discussion, I think, of whether it's appropriate, whether the patient's symptomatic, how much the disease is affecting their life. But I'm going to defer to Dr. Giralt for more information.
So smoldering myeloma, it's another moving target. So when I started in the field 30 years ago, you had to have either hypercalcemia, renal failure, anemia, or bone lesions to be treated. Those were the famous CRAB criteria. And then the group at Mayo and the group at Spain started seeing that there were not many patients who were coming in quote unquote asymptomatic or without CRAB criteria. And within 2 years, their first manifestation of disease was either renal failure or a fracture. And you imagine how painful it is for a physician who's been monitoring a patient for 2 years, seeing a patient come in like that and saying, maybe I should have done something earlier. And they initially identified these criteria, which we now call criteria of active myeloma: free light chains ratio greater than 100, bone lesions or lytic lesions seen on total body MRI or PET CT, and bone marrow plasmacytosis of more than 60%. So those patients no longer have asymptomatic myeloma. They have active myeloma. They need to be treated. But moving further, this is a continuum, and particularly with the use of all the lab tests that we have, a patient may be, we don't know if a patient has a smoldering myeloma or we simply caught myeloma early. So I think the first step with a patient who with newly diagnosed myeloma, who has no CRAB criteria, who has less than 60% plasma cells and have no criteria of active, is to monitor them carefully in the initial couple of months, once a month, once every other month, to get a feeling of, is this myeloma I caught early, or is this truly a smoldering myeloma? Once the patient has shown stability for a couple of months, we do have there are what we call high-risk smoldering myeloma. There's a variety of criteria. Think about it. There are people who have between 20 and 55% plasma cells in their bone marrow. There are people who have very low immune globulins. These people, based on large data sets, are predicted to progress to multiple myeloma within the first 2 to 3 years. So what did the Spanish do? They said, why are we going to wait? Let's put them on lenalidomide. They did a randomized trial, half on lenalidomide, half on observation. The people on lenalidomide, one would expect, progressed a lot slower because they're on active treatment. But the surprise to everybody is they actually lived longer. The ECA group did a similar study here, which again shows a progression-free survival benefit still has not shown a survival benefit. Because I think one of the things we need to remember when we start treating smoldering myeloma, everybody gets the side effects of treatment. And then the other option is if you're being watched carefully, the years that you're watched without treatment are years that you gained without any side effect. Let's say if you get treated with Revlimid and you have diarrhea and rash for 10 years and you were, I have patients with smoldering myeloma who would have been qualified as high risk who haven't progressed. Now, today we're saying if you have a patient who's been a smolderer for 10 years, don't do anything. And I think Dr. Cherry from Mount Sinai makes a great point, is that the criteria for smoldering shouldn't be a picture. It should be a movie. It should be assessments over a short period of time, 3 to 6 months, and see, does this patient actually have a disease that seems to be stable and unmoving? Or is this patient slowly growing? Is that paraprotein peak going up? Is that light chain going up? Those are two different entities, and I think those patients need to be treated early. And the treatment now, there's a trial that's being done at MD Anderson with isatuximab. We are participating in that trial. And I think the other thing, and getting a little bit into the weeds here, is that there are patients where the paraprotein peak produces symptoms. So I actually have a patient who had a paraprotein peak, only 25% plasma cells, but the paraprotein peak was producing an autoimmune disorder, bad arthralgia, stomach pains, and this and that. So we treated her on the protocol, and her symptoms have totally resolved.
Wow, that's amazing. Great. Okay, so now we're going to switch gears a little bit and talk about autologous stem cell transplantation. So, Dr. Giralt, I know this is a common question you get, and our patients still want to know, when we get a question like this at every single patient education event we have, is how old is too old to get a stem cell transplant? We have patients who are in their 80s or beyond who are asking that question.
Age is no longer a criteria. I think what we do is whether a patient is fit or not fit, and what other comorbidities they have. If you have a myeloma patient who's 85 years old, is totally fit, independent in all their activities of daily living, particularly if it's an ISS stage 3, in which even quadruplet therapy means that remission is going to last a short period of time, we would consider that patient a candidate for transplant. Now, transplant's a choice. It's a choice patients make based on the recommendations we give them. I think you asked, when would you not collect cells? I don't collect cells in very few patients over the age of 85, because you're 85, unless you have really bad myeloma, your life expectancy is probably 10 years, and that's more or less the life expectancy of a myeloma patient now, and it's even more. So I do think that it's not that age is an absolute barrier, but we do incorporate age in our decision about whether we recommend transplant or do not recommend transplant. And then it's really, up to the age of 85, we routinely consider all patients, as long as they're fit and independent in their activities of daily living.
Yeah, that makes sense. So Emily, can you walk us through how patients might prepare for a stem cell transplant, and then what their caregivers should prepare for before the transplant and then after the transplant?
Absolutely. So I think the biggest thing for both patients and caregivers is to ask questions. Ask questions of their provider, what to expect. Some questions I can think of are, what is collection like? What do I have to do to have my stem cells collected? What do I experience if I take Neupogen, which is a growth factor to help collect stem cells? What is the conditioning regimen? What are the side effects of the chemotherapy? Conditioning regimen meaning the chemotherapy given prior to the transplant. What is the expected course? How long will I have these side effects? What are you monitoring while I'm in the hospital or now out of the hospital? Are you checking my blood daily? What does the blood work mean? Will I need blood transfusions? Will I be inpatient or outpatient? And why is one better for me than the other? What is the recovery like? And what things should I be looking out for? Is nausea normal? Is diarrhea normal? Are fevers normal? And what should I alert you to? Which is generally everything. We want to know everything. The caregivers, similar things, educating yourself about potential side effects and what is normal, meaning, okay, maybe I have my spouse or parent or brother, sister has some nausea, but what is too much nausea that this needs to be taken care of immediately? Fevers are considered an emergency. Helping with food preparation, what kind of foods am I able to eat, or what is my family member or friend able to eat, and how can I prepare for that? And then I think assisting with medication management at home is really important, just because it can become overwhelming. The number of medications, what are they for, and the frequency, because a lot of these medications are critical in terms of preventing infection and shouldn't be skipped. And then some patients do find it beneficial to speak to another patient around the same age bracket that they are in, maybe the same disease, what was their induction like, and what are we doing to proceed to transplant? This can be helpful for some people to have this conversation with another person, but it can not be helpful, where it can increase somebody's anxiety. So asking your provider, is this something that would help or hinder my mental and emotional preparation for the transplant?
That's really good advice, actually. It makes me think of a good education tool we could develop with all those questions. So Rich, so you mentioned that you opted to have a stem cell transplant. So can you talk to us a little bit about that decision? Was it hard?
Well, 10 years ago, it was clear, at least to me as a patient, hearing things, is that the gold standard clearly was a stem cell transplant. So the question for me wasn't whether to do a stem cell transplant or not, it was what type. And so I had to make the decision. The brainy work had to go through whether it would be donor stem cell or autologous. And after doing some fancy statistical work and everything that our then son-in-law did for me, we decided that autologous was the way for me. Mm-hmm. And with what Emily was saying, with caregivers, my wife has, for obviously now for longer than 10 years, but the past 10 years she has been what made me get through stuff. Mm-hmm. And so there was at the point where she had to learn to give me the Neupogen. Mm-hmm. And because back when I had it, it had to be within an hour of giving the stem cells. And in New York traffic, I would be late coming in from New Jersey. So I stayed at Hope Lodge and we'd get the shot. Well, so Nan was practicing it and they were saying, good, great, perfect. Next time, do it and keep your eyes open this time. And she did it. Great. Going around, and it worked. Mm-hmm. Then for 4 days, we harvested and we got the number that Dr. Giralt wanted. And so then we rested a little bit and then we came in to get them back. But so that's the decision about stem cell or not was different, I think, 10 years ago than it is now. Sure. But I understand. Yeah. But it was the question of whether it would be my own donation or someone else's. Mm-hmm. Mm-hmm. And just statistically, I went with my own.
I think that most people do, right? There's not that many allo transplants done. I think Dr. Giralt, you're one of the few proponents.
Yeah, so I think,
right?
what we think allo transplant is a valid alternative for patients with high-risk disease, particularly if they're young. Mm-hmm. So if you're 37 years old, your life expectancy should be about 50 years. Myeloma is going to cut that significantly. There is data emerging from long-term follow-up of both the American and the European study. The patients with high-risk myeloma, particularly young patients with high-risk myeloma, had longer remissions, durations, and actually better survival if they had an allo transplant up front.
Mhm.
The other place where we think allo should be explored primarily in clinical trials is in patients who are multiply relapsed or who relapse early after primary therapy, particularly if they're young, because these myelomas have very poor prognosis. So I think I wanted to echo, I think, what Rich said is true. I mean, 10 years ago, we said, we didn't have all the drugs we had today. We didn't have the knowledge of how effective we can rescue patients with myeloma. So many patients are opting for delaying transplant. Today, I mean, we just heard, and it was just published in the New England Journal of Medicine, one of the largest studies comparing the outcomes of patients who had delayed transplant versus patients who had upfront transplant. So in the context of upfront transplant, that first remission lasted 2 years more in the patients who got transplanted upfront versus the patients who opted for delayed transplant. Interestingly enough, at this time, with 7 years follow-ups, the survivals are the same. But I always tell patients, transplant's a choice, it's not a necessity. You need water, you need love, you need air, you need food. Transplant's a choice you make based on the conversations with your physician, based on the perception of how you're going to do with or without a transplant.
Mhm.
What do I think is significant? If you have not had what we call a measurable residual disease negative complete remission to your primary therapy, you should seriously consider getting high-dose melphalan. Those cells that are there are the cells that are resistant to the best drugs that we have available. And high-dose melphalan has been shown to be effectively get rid of those resistant cells and put you into an MRD negative complete remission. That's one thing. In a patient with older patient, low-risk disease who achieves a complete remission to primary therapy, you can think about, well, maybe I want to delay it. Although, again, the determination study showed that first remission is going to last a lot longer if you have a transplant up front. We do think that, unfortunately, salvage transplants and second transplants are very underutilized in the United States. Only 1 out of 3 patients who relapsed on the determination study actually got a salvage transplant, as opposed to 7 out of 10 in the French study. Now, Dr. Richardson has said, well, that's, because the survival is the same. But I think it's not just about survival. It's about how many lines of treatments, how deep is the response of the patients who did not get transplanted versus those that got transplanted as salvage.
Mhm.
So I think the determination study teaches us a lot.
Mhm.
The field has changed a lot in 10 years, so we now do quadruplets. But I do think that high-dose melphalan is here to stay for at least a while.
Mhm. Mhm. So just out of curiosity, if Rich had chosen to get an allogeneic transplant from a donor, I mean, how hard is it to find somebody who's like a bone marrow match?
So, that technology has also changed. When Rich was going through this conversation, we talked about it. I also recommended that we do an autologous transplant. Although he had extensive bone disease, he had no high-risk features. And at that time, you had to have a 10 out of 10 match. Now, with the advent of a technology that we called post-transplant cyclophosphamide, we can actually do mismatched transplants with results that are comparable to fully matched transplants. So in 2022, everybody has a donor.
That's amazing. I did not know that. Who knew?
Yeah. Things evolve.
They do evolve. That's very interesting. So, okay. So, Emily, for patients who have completed induction therapy and then they had their stem cell transplant, or even if they didn't get a transplant, so then what happens next? Do they undergo assessment for their response to their initial therapy and or the transplant? And if so, what is measured and what's the goal of the response? I mean, how do you want to see patients respond to that initial sort of first line of therapy, which may include a transplant?
So whether it was induction therapy without transplant or after transplant, restaging would occur, and that does include blood monitoring. So some of the levels that Dr. Giralt was mentioning, the free light chains, you can remeasure the beta-2 microglobulin. There's a myeloma panel that should be checked. Bone marrow biopsy to assess for, again, what Dr. Giralt was mentioning, minimal residual disease. So looking for 1 in a million cells that is left behind after induction or transplant. And then repeat imaging if the patient did have myeloma outside the bone marrow detected on prior imaging before the transplant or before induction. So restaging is usually done after this last cycle of induction or usually 3 months after the transplant is performed. And this just allows the body time to recover from the transplant, the chemotherapy that they received. And then usually after we have the restaging results, that's when we discuss maintenance therapy, which is often suggested in order to prolong and deepen a patient's response to either induction or transplant. Ideally, we would have no minimal residual disease detected. The labs, the blood work that we checked would have no evidence of myeloma, and imaging would have no evidence of myeloma. Regardless of whether or not a patient had all these three results showing no myeloma versus minimal residual disease, we would recommend maintenance therapy. If there is active myeloma, meaning more than minimal residual disease, a further discussion needs to be had whether or not another induction therapy line or further treatment after transplant, more so than maintenance therapy, is required.
Yeah. Okay, so let's talk a little bit about MRD testing. So is that at this point, Dr. Giralt, like a standard process at most doctors' offices or not? And when is the best time to get MRD tested?
So it's not so there is a commercially available measurable residual disease test, which is monitored by Sequenta. It is a bone marrow test, so it's not, you have to get a bone marrow aspirate to do it. It can get sent to a central lab where it gets done. The other ones that we do, particularly in large academic myeloma centers, flow cytometry. Both of them can measure between 1 in a million to 1 in 100,000 myeloma cells. Obviously, the lower the number, the better it is. Many of us believe that it should be standard. It is not standard yet. Although Sequenta is available across the country. When should it be done? Well, we think it should be done in patients who've achieved a complete remission or a very good partial remission. That's where it becomes informative. We know that patients who have measurable residual disease negativity at the 1-year mark post-transplant are patients who are unlikely to relapse within the first 2 years after that test. Patients who have an MRD positivity at the 1 year post-transplant, 30% of them may be having to deal with their disease within the next 2 years. So it does differentiate. What we don't know yet, and these are studies that are being planned, is if I have a patient who's MRD positive, should I try to convert them to MRD negative by adding something else? And will that change the natural course of their disease? So those are studies that are being done, what we call MRD guided treatment. Dr. Luciano Costa and the group at Masters did a very interesting study in Induction in which patients who had sustained MRD negativity for 2 years were allowed to come off the lenalidomide maintenance. And those patients do not seem to be relapsing if they were standard risk. If they were high risk, those patients are relapsing. So we're learning that, some people can come off lenalidomide and not relapse. But for most, and I think the Stamina study also showed that at 3 years of lenalidomide therapy, if you stop lenalidomide, your risk for relapse was higher, almost twofold higher over the next 3 years than if you stayed on lenalidomide maintenance.
Interesting. So, Rich, what was your response to your initial therapy? And did you have MRD testing? And how did all that go?
I found out earlier this afternoon that I did. But literally, it was I did not know that it was being done, by Dr. Giralt. He would report to me, but never called it, to my knowledge, at least, the minimal residual disease. So I get that regularly. Talk to him about that. But as far as my treatment is concerned, I am on Revlimid, and for a long time I was 28 days straight, and then I have shifted maybe 3 or 4 years ago to 21 on, 7 off. Nan, my wife, thinks of the Revlimid, lenalidomide now as Pac-Man, just going along, eating up the myeloma. And so we made the decision a couple of years ago to continue on that therapy. I've been very fortunate. One, it was nice to have Wellcol entered into my life, but I had been no significant side effects at all. So now, whenever I'm off Revlimid for any duration of time, we get sort of freaky. But which last month I had hernia surgery, and so I had to go off Revlimid because of aspirin for 2 weeks, and that just seemed too long. But
it gives you some level of comfort that things are staying under control with that, which I guess is really well, right? It's kind of like peace of mind. You have peace of mind for that.
And as as Emily was saying, it's important that the patient and the caregiver feel active in taking care of themselves, and so I'm that's part of making sure that I'm faithful to the Revlimid and all the other tangential pills I have to take and stuff like that.
Right. So good for you. So I know we're up against the clock a little bit here. I know, Dr. Giralt, you have a hard stop. Can you just quickly tell us about maintenance therapy and what is it and what drug is most commonly used?
So maintenance therapy, this is again where clinical trials are so important. And again, to everybody on the webinar, if you're offered a clinical trial, seriously consider participating. It is what establishes the standard of care today, and it establish the standard of care today, and it will establish the standard of care tomorrow. So in 2010, we did what's called the CLGB 100-104, which was a similar trial that the French were doing, randomizing patients to maintenance therapy with lenalidomide versus placebo. And at that time, there was a lot of doubt that continued treatment would actually make a difference in myeloma. There were people who say, oh, you're just going to make the cells resistant. Why don't you just leave them alone? And then when the disease comes back, you put them back on lenalidomide. Lo and behold, not only did the remission from the transplant last 24 months longer, but people actually lived longer. And the benefit, I mean, this study was done through the Blood and Marrow Transplant Clinical Trials Network and the CLGB, the Alliance. And if you think the amount of years this intervention has saved, we're talking about hundreds of years of lives saved by this clinical trial, and it's now the standard of care. The French has said, oh, we only do lenalidomide for 2 years. So again, the Stamina trial suggests that, no, you should continue until progression. Lenalidomide is the most commonly prescribed maintenance. It's prescribed anywhere between 5 and 15 milligrams. Now it's common to give that week period that Rich is talking about. In patients with high-risk disease, we're learning that lenalidomide alone may not be enough. There are clinical trials with bortezomib and lenalidomide which show positivity. There's clinical trials with lenalidomide and daratumumab which are currently being done, which also suggests that for patients with high-risk disease, there may be a benefit for the combination. Dr. Gay just reported the Forte trial where lenalidomide was combined with carfilzomib. And that maintenance strategy was better than lenalidomide alone across all patient categories. So I do think that we are going to see combined maintenance therapy as continued treatment for patients. The goal is to our goal, remember, is the same, is to give people the longest life with the best quality of life with the right amount of treatment.
Right. Okay, so I'm going to go now to some concluding thoughts. So basically, what advice would you give a myeloma patient who's navigating treatment options and the question of transplant or not? Dr. Giralt, as I know you have a hard stop, I'm going to let you go first. This is going to be lightning round.
Okay. No, the things I always tell patients: inform yourself, go to websites like the Multiple Myeloma Research Foundation. I strongly encourage them to talk to a patient who's going through the journey. And then, I also strongly encourage them, if you're a physician, if your local oncologist is not a myeloma expert, get a second opinion with a myeloma expert. It is worthwhile. You don't have to change treatment. You can stay with your local oncologist, but it's worthwhile. And I do think at the end, I'm a transplanter. I strongly encourage patients to get transplanted because I think that first remission, that longer remission that's shown in determination makes a serious difference.
Great. I totally agree with you there, and that's really great. If you feel like you want to jump off, you may.
Well, I want to say thanks to Rich and to Emily for participating here with me, and to the MMRF and you for moderating. Once again, thank everybody who's on, and I'm hoping to do more of these. Thank you all.
Great. Thank you for being with us. Really appreciate it. Bye-bye. Okay, Emily, your parting thoughts to patients about transplant.
So something that I learned from working with Dr. Giralt for many years is that, one, he has a lot of sayings, but one is that,
all these doctors seem to have a lot of sayings. I found that to be true.
I know. So with all these studies and the data that we have is that we're looking at a forest and each person is a tree. So treatment is not one size fits all. And there's many reasons to consider one induction therapy versus another, transplant versus non-transplant. And so you want to be comfortable that the provider that you're with is looking at you as an individual and using the data at large as well. So they're looking at the comorbidities that you have, how your disease presents, your response to initial therapy, your age, your performance status, so meaning how strong and robust you are. So just be comfortable that your provider is looking at the whole picture. Like Dr. Giralt said, I work in transplant as well. So transplant is generally speaking the best way to prolong and deepen your response to initial therapy. But you need to be a good candidate for that. And you also need to be in a good mental headspace to prepare for that. And not everyone is, and that's okay. It is a choice. So the best thing I think is proceeding based on all these factors, and that also your provider is treating you as an individual.
Yeah, no, I totally agree. And it seems to me like listening to the three of you talk, right? So this is like the care team, right? You have the patient, and then you, Emily, and Dr. Giralt all working together in the patient's best interest, right? So this is probably the third Facebook Live that we've done, and sort of listening to care teams like this talk to each other is just really a model, I think, for other patients to see how it can be done, right? And the sort of mutual respect and discussing what goals are, and then, just really, doing what everybody thinks is the best for the patient.
Absolutely.
Do you have any parting thoughts, Rich, along those lines? I would say that you're quite lucky to be with this care team that you're with.
That's true. It really is. Yeah. When I was diagnosed, unfortunately, the church I was serving at the time had other ministers die of cancer. And so how do you do it? I decided I was going to be upfront all the time. When I was in the hospital initially, Nan would give reports on where I was doing. I got back and I used the analogy of the red convertible. You buy a red convertible, and then the only car you see on the road are other red convertibles. And that's exactly what happened to me once I had multiple myeloma. And so I'm appreciative of the wisdom Emily has shared about talking to other people about it. And I'm happy to do that. I've enjoyed that. It's been important to me, and I hope it's important for other folks. It is, in a very real sense, that it's a change of lifestyle that the patient has to go through, and the primary caregiver. But I am very appreciative of the ongoing care that Dr. Giralt and the team, including Emily, has given me for now a decade. And I'm also glad to share, and talk with other people. Though everybody's cancer is their own.
Absolutely.
It's so. As a social ethicist, I'm really willing to tell a lot of people how to live, but I'm not willing to tell anybody how to handle their cancer.
How to handle their cancer, right? So a lot of people have cancer, and it's different in every person, right? And you can talk about what you went through, basically, but it may not be what this person goes through, right?
Yeah.
So but I think everybody really appreciates listening to other patient stories. And we certainly found that to be true. And it's very, very valuable for patients to listen to other patients' stories, even if what the other patient is telling you has no relationship to what you go through or what you may go through or what you have gone through, because it can be so different for every patient. So this has been a really great hour. I really appreciate talking to all of you. Thank you so much, Rich, and thank you, Emily, and thanks to Dr. Giralt in absentia for being with us today. So it was really a great conversation. I love having these conversations with patients and care teams and really seeing how they work together in the best interest of the patient. That's just so inspiring to me. So I'd also like to thank our sponsors for this event, Adaptive Biotechnologies, Genentech, GSK, Janssen, Carrier Farm, and Takeda. We wouldn't be able to do these programs without their help. So, and I'd also like to mention that if anyone has additional questions about what you heard today, please don't hesitate to call our Patient Navigation Center. Their phone number is 1-888-841-6673. They're available from 9 o'clock in the morning till 7 o'clock at night Eastern. And we have 3 or 4 oncology nurses on the phone that can answer your questions. So again, thanks for being with us today. And Rich, best of luck to you. Best of luck to you.
Thank you.
Emily, it was really nice talking to you. So.
Yes, my pleasure being here. Thank you for having us.
All right, thank you, everyone, and bye-bye.